Perhaps can you disconnect me from your side?
Let me see. Right. Good afternoon, ladies and gentlemen, who have joined us on this Dr. Fundi channel via multiple social media platforms, by Facebook, YouTube, Twitter, Instagram, and also via the Dr. Fundi website. My name is Fundi Lenyati, and I am the host on this channel. Welcome to our first installment of what we refer to as the Pakamisa Saturdays. This is the first of a number of shows that we are going to have on Saturdays on various aspects of this Pakamisa project, which is a project of Astrazeneca. Now, today, I've got special guests, from guests from Astrazeneca, also Dr. Mulifi from Steve Biko Academic Hospital. I also got Ms. Salome Meyer, who's coming from Breast Cancer Alliance, and also Dr. Kulumbata. So I'm just gonna go through the brief bios of my guests, and then I will welcome them, officially. So I'll start with Ruth. Ms. Ruth Field is the Market Access Director for Astrazeneca South Africa. She leads the strategic direction of Astrazeneca's access strategy for our, for the Astrazeneca portfolio, which includes pricing and reimbursement as well as government affairs. During her extensive experience in the pharmaceutical industry, spanning several high-impact, positions, she has been instrumental in developing and implementing innovative access solutions, achieving optimal pricing, reimbursement, and other access conditions, as well as securing high-level government affairs engagements. She is recognized an active leader in South Africa's biopharmaceutical industry, serving as AstraZeneca South Africa's representative with government officials, industry trade associations, and influential policy organizations. She leads AstraZeneca's Pakamisa program, partnering with multiple stakeholders to lessen the burden of non-communicable diseases in the South African healthcare system through promotion of primary prevention, early detection of diseases, access to care, and the program currently focuses on the breast and prostate cancers in the public sector. She also leads the non-communicable diseases screening partnership with the Ministry of Health in South Africa. So that's the bio for Ruth. Ruth, welcome to the Dr. Fundi channel.
Thank you very much, Dr. Nyati.
All right. Let me also introduce Dr. Tulo Molife, the other guest of ours. Dr. Tulo Molife is a specialist and senior lecturer in the Department of Medical Oncology at the Steve Biko Academic Hospital and the University of Pretoria, where he treats a variety of hematological and solid malignancies, that is cancers. He is also a member of the Pan-African Cancer Research Institute Management Committee at the University of Pretoria. He obtained his MPhD from the University of the Free State in 2009, followed by 2 years of internship in the Northern KZN and 1 year community service in the Northwest Province of South Africa. In 2013, he joined the Durban Circuit of the University of KZN, Internal Medicine Specialty Training, and became a fellow of the College of Physicians of South Africa in 2016. He later obtained a master's in medicine from UKZN, and he joined the Department of Medical Oncology at the University of Pretoria for subspecialty training in 2017, and wrote and passed European Society of Medical Oncology certification exam at the end of the fellowship training in 2019. So he's still fresh from the box as a medical oncologist. In 2020, Dr. Molife registered for a PhD in medical oncology with the University of Pretoria and was shortly awarded South African Medical Research Council Clinician Research Program scholarship grant towards the completion of his PhD, which is focusing on the genomics and the health disparities of cancer in South Africa. Right. Now, I also want to introduce my other guest, Salome Meyer. She is a qualified social worker at the University of Pretoria. She qualified in 1981, and worked as a social worker for quite some time. She, obtained her BA in social work, medical social work, honors in the US in 1982, obtained the Master in Social Sciences, UCT degree in research in 1988. She has worked as a research social worker at the Red Cross Hospital from 1982 to 1984 in the Child Safety Unit. She specialized in community development and worked at local, provincial, and national level of government for 15 years, from 1984 to 1996. She was responsible for training of staff as well as top management and political leaders in community development and all related development aspects. Of interest today, she has been involved in cancer advocacy and development training since 1996, developed the advocacy program and strategy for Cancer Association of South Africa in the early 2000s, served as a member of the board of directors at Cancer for 3 terms, chairperson of the Western Cape Cancer Association, who advocated for the improvement of radiation services and served on the ministerial task team, which resulted in the improvement of service delivery at 2 tertiary institutions and a public-private partnership agreement for a distant health district. She has served as the chairperson of the research committee of cancer. She has developed a research paper at UICC in 2006 conference in Washington on the use of dendrogram technique to identify priority advocacy issues. So I think her CV is quite long, but all I can say is Salome is somebody who has so much passion. She's got so much interest. She works, on the ground, but she's also able to work at all levels as an influencer and as also, somebody who is comfortable in the pushing decision makers to do what they're supposed to do. Salome, welcome to the Dr. Fundi channel. Please unmute.
Thank you, Dr. Fundi. Nice to be with you and your listeners and the rest of the team.
Thank you for joining us. Ruth, Dr. Munife, and Salome, you are all welcome as my esteemed guests. And we are going to have a nice chat. It's going to be an informal chat. We are going to converse, about issues relating to cancer in South Africa. But obviously, we're going to be focusing on the cancers, breast cancer and prostate cancers, which are the main ones that are targeted by the Pakamisa program. But before we do that, I want to also just highlight the fact that today, the 12th of December, is the 6th Universal Health Coverage Day. On the 12th of December in 2012, United Nations decided, and in fact, there was an agreement or a resolution that every 12th of December should be a day to advocate for universal healthcare coverage across the world. And only in 2014 did the Universal Healthcare Day start. And so today, as a country, we are actually celebrating that day. And that is all about ensuring access to healthcare for all the peoples of the world. Quality healthcare that does not depend on how much money one has. So the theme for this year is health for all, protect all people. I thought it ties in very well with the Pakamisa project, which is also amongst its pillars is about improving access to healthcare. So welcome once again, and I'm just gonna pose a question to all of you, just a few seconds of just answering that question. I'll start with you, Salome, if you don't mind. cancer, obviously there's many cancers out there, but the challenges of cancer in the country, we are told that it's a growing problem. From your vantage point, when you just look at cancers broadly, what is your sense about the prevalence and how South Africa is dealing with them?
Certainly cancer is on the increase, and we need to understand also that cancer is a disease that affects all people. So it doesn't discriminate. So all people, all age groups can be affected. However, it is a known fact that cancer actually affects more people in the older generations. And what we also have, and I think that's very important in the South African context, is that with the success of HIV treatments and people being on ARVs and living longer, we will have a group of people that will definitely then also be diagnosed with cancer, because there's a number of cancers that is associated with HIV and AIDS. So that in itself is going to become a disease burden that we need to look at. And I think if we particularly look at the main cancers, women, we are still talking about cervical cancer. There's a very definite link there with HIV. Breast cancer, that is, that we know is a very high incidence. Prostate cancer is becoming a serious problem in this country, and is going to grow exponentially. And that, unfortunately, has to do with men's health-seeking behavior. We also know that lung cancer is on the increase. Again, you're talking about smoking, environmental issues that impact there. And then we are seeing that your blood-related cancers, again being linked with HIV, is increasing and is going to increase. So certainly for the next 10 years, I think that we will have a bigger problem in South Africa. So there's going to be a far bigger challenge on government on how to actually make sure that we deal with the crisis. And I say crisis, because the cancer is not a cheap disease to manage. That, unfortunately, is the other aspect. However, on the other side of that, there is a lot that every single person can do in order to make sure that you prevent cancer, or either make sure that you are screened regularly and that you detect your cancer earlier, because the earlier you detect your cancer, the easier it is to treat it, and therefore increasing your survival for cancer.
Thank you. Dr. Molefe, just your opening remarks about, the caseload of cancers in the country before we focus on the Pakamisa project, of which Ruth will be the next speaker to now tell us from her vantage point, and then tell us about the Pakamisa project. So over to you, Dr. Molefe.
I think the caseload from cancers is that what we see in females, breast cancer is the most common cancer in females in South Africa. However, it does have a racial thing. It's that cervical cancer is still the most prevalent in Black females. However, on a total scale, breast cancer is still the main problem in females in South Africa and the world. In South Africa, prostate cancer is the second most prevalent cancer after basal cell cancer of the skin. So, however, but in males, prostate cancer is the most prevalent cancer that is most prevalent in the country. But what we see in our clinic is also echoes those sort of statistics as well. Yeah. So breast cancer keeps us quite busy in our clinic. There isn't a week that goes by that we do not see a woman with breast cancer. I think even a day going by would be quite shocking. Yeah. Prostate cancer, we see quite a lot of it as well, but it's not as frequent. Whether males are not coming in, or they wait until calamity has struck and nothing can be done. Yeah. So that is the sort of sense that we get in the disease profiles. And the funny thing is, lung cancer is a problem. The thing that we do not see is what is seen overseas. Lung cancer is the most common cancer and the most leading cancer of cancer death in the world, but we don't see that. And I've got my personal thoughts on why that is. But I think as time goes on and as screening becomes part of our culture, those numbers will make themselves apparent.
Yeah, thank you, Doc. Ruth, your take broadly on issues of cancer being one of the non-communicable diseases that is adding to the burden of disease in the country. And also maybe you can start to also tell us about the Pakamisa project once you have given us that first take.
My take on cancer is that it's actually increasing, and there are a lot of people that are affected. In any family or in any area, you actually know somebody that is affected by cancer. So it's one of those non-communicable diseases that we need to really focus on. And Pakamisa is actually focusing on that. Pakamisa is a non-communicable disease project. So its focus is not just on cancer. It does focus on other non-communicable diseases. But at the moment, we're prioritizing cancer, specifically breast cancer, because it's the most common in women, and also prostate cancer being the most common in men. Pakamisa is a program that we started in 2011. So it's an ongoing program. However, in our discussion later, you'll find that the reason why we're relaunching it now is because we've changed the model slightly because of other things that we've picked up from the initial Pakamisa that we had. So it is meant to serve, uplift communities, and also make sure that communities are aware of non-communicable diseases. They own the diseases, they understand, they take the responsibility, they don't shift the responsibility to caregivers. Yeah. And Pakamisa's vision is to actually make sure that there is awareness in communities, there is early diagnosis and effective access to care. We want to make sure that we increase the chances for successful treatment and survival of both breast cancer and prostate cancer patients in government facilities. Because these cancers, if they're detected early, the patients don't have to die. But most of these patients are dying mainly because they get into the institutions quite late, or if they get into the institutions early, the healthcare practitioners sometimes miss those cancers. So by the time they get the diagnosis, by the time they are treated, it's actually very late. We want to promote a patient-centric center care through an integrated program. We want to make sure that everybody in the institution knows what to look for, because the patients don't just always start on oncology. They actually start across the entire 4 levels of care.
Yes. So you mentioned, Ruth, you mentioned that the program, the Pakamisa program, has been in existence since 2011, right? Which would make it about 9 years old. And the big focus was on the navigation of patients within the maze of the healthcare system once people are suspected or have been diagnosed with cancer, breast cancer. Can you just say a little bit about that, the successes that the program has had, in the last 9 years? And yes, there's been a retweaking of the focus now, but we have to build on what has been there.
Yes. So initially, the program was actually being run by the Breast Health Foundation in partnership with Astrazeneca. And the navigation was done by cancer survivors, breast cancer survivors. So they would actually start in the communities, then they'll help the patients to actually navigate the system into the clinics and basically take them obviously to tertiary care. So this program was very, very successful because during that time, we managed to train about 600 healthcare practitioners, because one of the legs for Pakamisa is education. That's one of the pillars. And then we educated 523 community navigators. Those are breast cancer survivors. They're almost like people that will be going and championing cancer in the areas and making sure that in those communities, they teach the patients. And then through this awareness, we reached about 1.48 million women. So that's a lot. And the malignant lumps that were actually found was 5,800. So through this program, we managed to find a lot of other things as well. There's certain things that we picked up. We picked up that the systems itself are not very functional in terms of the upward and the downward referrals. And then there's also no digital system to link what's happening in the communities and what's happening in the 4 levels of care. So it's almost fragmented. And then we also realized that there are community healthcare workers that are working in the communities, but they don't really fit smoothly into what is happening into the clinics and the district hospitals and the tertiary hospitals as well. The other thing that we found out was that in terms of the policy is there, the breast cancer policy, but in terms of the implementation is not optimal. So then we decided to say, okay, we need to change the model of Pakamisa. Instead of just focusing on the navigation, we want a model that is more inclusive, that includes government, but also includes the communities. And we wanted to actually go across the 4 levels of care. And then we also want to make sure that civil society is involved, because civil society is the one that works actually with government most of the time in terms of the policy creation, and also agitates for the implementation of the policy. And if you look at the earlier models, I mean, those stakeholders were not really featuring as much. So we want to make sure that they feature a lot. But we also want to make sure in terms of the awareness, we optimize awareness in the community through the various mediums that are actually available. So it is getting bigger, it's becoming more inclusive, it's becoming more collaborative as well. And we also want to make sure that it is outcomes driven. That's why we've also partnered with a digital company. So we're implementing a digital system that is actually going to show visibility from end to end across the entire patient journey. That way we'll be able to actually have data that will be used for publications, but also data that will actually be able to show costs. Because the other thing that prevents institutions sometimes from getting budgets approved is because they don't really have tangible data that they can use to back up whatever they're motivating for.
Yes. Thank you very much, Ruth. Thank you. I'm going to come back to you, Salome. You are on the ground. You are coming from Breast Cancer Alliance, which is an umbrella body of many NPOs that are involved in one way or the other in dealing with matters of breast cancer and other cancers. Now, you were also a member of the ministerial committee that came up with the breast cancer policy that was released in 2017. Now, I just want your take on, you are obviously aware of the Pakamisa project, to date, the good work that has been done by the Breast Health Foundation. So I just want you to share with us, just from your vantage point, how you've seen the program, in the last 9 years or so.
I think over the last 9 years, we have achieved a lot in South Africa, first of all, to bring cancer organizations together as one voice. And I'm going to take one step back and saying, in the early 80s, the cancer organizations already started asking government for policy. And I can actually share this with you that when I started in cancer, there were only 2 organizations. And that was Reach for Recovery and the Cancer Association. Oh, wait a bit, and also the Childhood Cancer Organization. Yes. And today, so many years later, 25, 26 years later, we have, I want to say, more than 40 non-profit organizations. So for government to talk to 40 organizations is very difficult. And government actually gave us that challenge and said that we can't talk to all these organizations. We need one voice that represents the cancer community. And that is where the cancer non-profit organizations got together and formed the Cancer Alliance, which is an alliance of all of the majority of non-profit organizations. Out of this, we then formed also the breast-focused organizations, and that was the Advocates for Breast Cancer. So many of our organizations at grassroots level have been involved with the earlier Pakamisa, and that is such as the Breast Health Foundation and Cancer Association, navigating and specifically playing that role of navigation in communities. I think what is the beauty of the current Pakamisa program is that it's now bringing all the aspects of training, awareness, and access under one umbrella, whereas previously it was actually just maybe focused on one side of it. And that for me is the actual beauty of the new, and I want to say the new look Pakamisa, and the challenge that we have in terms of making sure that we roll it out also to all communities in all provinces in an equitable way. I would like to say this, that in 2014, we formed the Advocates for Breast Cancer, and we started to put the pressure on government and say, because breast cancer is such a problem in this country, we need a dedicated policy, because if you have policy, you will make sure that there is no difference between the way a woman is treated between Limpopo and the Western Cape, or between the private sector and the public sector. And that in itself is also the other beauty of the Pakamisa program, is that we are systematically going to make sure that that vision of equitable services is going to be rolled out in all our provinces.
Beautiful, beautiful. Now, that is on the breast cancer, policy side of things. But then the other area of focus for the Pakamisa program going forward is, the prostate cancer amongst men. And is there a policy just like on the breast cancer side for prostate cancer? And if it is not there, what do you think is the reason why it's not yet there?
So in the same breath as breast cancer, the government then realized that for the top cancers, there is definitely a need for a policy. So they initiated the policy development process. I think it was about 2017. We are currently awaiting that policy to be finalized. And literally we're talking about aspects of costing, making sure that all aspects of the policy is costed, that provinces will be able to take on the responsibility. And I think it's important that our listeners understand this. When a policy is approved by government and accepted by government, it then means that you as the citizen actually is then entitled to your constitutional rights. So the moment that the government takes on a policy and the province starts implementing it, you can say, this is my right. So the provinces will not necessarily take on the policy until they have made sure that they have got sufficient budget, because if you don't have sufficient budget, you cannot implement a sustainable program. And I think that is being responsible from a government side. So we are awaiting that part. But I think the biggest challenge that we do have, and this is again where I think that the Pakamisa program is going to start right at the beginning, and that's the awareness side of it, because we will have to do a lot in our communities to change the health-seeking behavior of men. And, Dr. Molefe has already said that, don't know if men don't come to the clinics or they don't. No, they don't. You guys know that that doesn't happen. And we need to start looking at how are we going to change the conversations in our communities, how so that men can start feeling comfortable to come forward, but also what is the role of women in changing that conversation for men to actually help them to so that we can prevent the late stage. And I really want to emphasize that it's for me about preventing late stage diagnosis.
Yes, yes. All right, let me get to Dr. Molefe. Can you unmute, Doc? Right, Doc, let's try and link with what Salome has just shared now. The focus, as we have heard from Ruth, of the Pakamisa project is on breast cancer, and also it's on prostate cancer. So there's a challenge, or there's an issue there that has been raised by Salome. The fact that as men, we tend to have help-seeking behavior that is not in our interests. We tend to not go and seek help. But can you just talk to us about what you are seeing in the area of prostate cancer? At least you've told us when it comes to breast cancers, almost every clinic that you guys have, there will be somebody with breast cancer. But when it comes to men, what trends are you picking up as far as breast cancer is concerned?
In terms of breast or prostate?
Sorry, man, prostate cancer. I'm sorry. Yeah.
We're seeing a lot of these patients that come late. They do present late to us with metastatic disease. I don't know whether is it, like I was saying, is it because as a medical oncologist and where we fit in prostate cancer is really at the tail end of it, at the metastatic end of it. So the fact that I, as a medical oncologist, only see a metastatic patient is, it's not wrong. So we don't know what's happening at the beginning. Are these patients de novo metastatic where they present at the local clinics, or de novo metastatic when they present to a urologist and then refer to us? And they all present early at the urologist and are kept there up until a point where they're metastatic and they require chemotherapy. So that's data that we really do not have, and we would like to have. And I think with this Pakamisa thing, that will be clearly drawn out and put out. So, but as to what we see a lot of patients who come at quite late stages. Sometimes we do get patients that are referred to as quite early, and then we do monitor them until something happens that requires treatment from our perspective. So yeah, that is what we see.
All right. Now, Doc, I still want us to zoom in now on the prostate cancer. How deadly is prostate cancer? I'm not sure if it's the question is an appropriate question. But when you read literature, you get a sense that some people, can get non or less aggressive type of prostate cancer, in which case they can live for longer, with some treatments, but others, they get the more aggressive form, which can actually then, lead to them demising. So in the South African situation or your experience, what are you seeing as far as, the type of prostate cancer?
Yeah. Prostate cancer is one of those diseases that as a man, if you live long enough, you will get. Right. From autopsy studies that are done in men in their 80s, you'll find that a lot of them have prostate cancer and die of something else. So prostate cancer is one of those diseases that are known for that. They're known for the slow progression, and some forms really do not progress as rapidly. But if one thing that we know, and taking data from obviously from the States and every other developed country, we know that prostate cancer is one of those cancers that have a racial disparity.
Yes.
We know that Black men, when they do have it, have a rapidly progressive disease, usually metastasizes early, and really responds poorly to the available therapy. So being a clinic that Steve Biko that caters for indigent population, which majority of them are unfortunately black, we do see this aggressive phenotype of disease.
Yes. Yeah. Now, from your literature review, and why are people of African ancestry actually, why are they likely to have this aggressive form of cancer, of prostate cancer?
Unfortunately, our genetics are not known. Africa is one of those places that our genetic makeup and genomics of disease, and particularly in cancer as well, it's really not known. And we do not know it because doing research on genomic studies requires a lot of funding, requires a lot of resources, which unfortunately most of the time we do not have.
Yes.
So in the US, where there are these resources to study these things, the population in the greatest human population, Black people only make up a minority of those studies. So when you really do not get much from that data. It seems like we lost Fundi there.
Okay. I'm sorry about that. There's a bit of load shedding happening here in Midrand, so I'm sorry about that. There was no notice for me about that. But can we just continue? Dr. Mulife, you were still on the floor.
I'm not sure at which point did you get, or
yeah,
you just read where did it cut for you?
No, just continue, because yeah.
So like I was saying, so when the genetics and the sort of aggressiveness as of why prostate cancer is aggressive in certain populations is done in an international setting, the numbers of Black men in that cohort are usually very low. So you do not get much in terms of signals instead as what is going on their genetic level. And in prostate cancer, we only know the genetics of it are really only starting out to be, untangled at the moment. The only sort of gene that's been well studied in a Caucasian population is the BRCA genes and its association to prostate cancer and stuff. As to the genes of Black men, we do not know. As we know that BRCA in a total Black population really doesn't play much of a role in the cancers. So genetics need to be studied.
Yeah. All right. Now, I just want to also, about 2-3 weeks ago, I attended a session for one of the big state-owned enterprises where they were focusing on prostate cancer. And one of the doctors there is actually a survivor of prostate cancer. Now, he mentioned that in his family, for a long time, there is no man who reaches the age of 50, and quite a number of them, they get diagnosed under the age of 40 with prostate cancer. As a result, as a routine now, they all go for screening at a much earlier age than what would normally recommend. So have you encountered that kind of situation where the risk is actually familial?
Not in my personal experience. We haven't seen that coming through in our clinics, but we know that when you do have a genetic susceptibility to developing cancers, we know that it's not just with prostate cancer, with a myriad of cancers, that if there is a strong familial susceptibility to this cancer, that screening usually needs to occur, what you would say, 10 to 15 years before the person who had the cancer in your family. So if, let's say, for instance, if your mother developed cancer in her 50s, we would then in that situation that advocate that screening in that family, and we know that there's a genetic predisposition, it would start at 40. And so that, we'd use that depending on which cancer, but the range is really a 10 to 15 year range that screening should begin earlier than the person who had the cancer in the family.
Yes. Now, you touched on this, the risk of prostate cancer, where the first degree relative is testing positive for that BRCA1 or 2. Can you just talk a little bit about that?
You can talk about it in terms of breast and prostate cancer. And prostate cancer, the more one that leads to more susceptibility is a BRCA2. Whereas in breast cancer, it's a BRCA1. And breast cancer, BRCA1 or 2 in breast cancer can play in different sort of subtypes of breast cancer. The triple negative subtype usually has a more BRCA1 incline to it, whereas the BRCA2 is more where males would develop prostate cancer, would develop breast cancer. So it depends on the gene, on the between 1 and 2. And how it would play out, the disease phenotype would play out.
But to the people, can we be able to say, if you have a sister or a mother who is positive for those genes, you are at a slightly higher risk than an average, or it doesn't matter?
No, having one person with this BRCA gene doesn't mean that you're at increased risk. There are many genes, just because it's there, it has different expressions, it's got different abnormalities, it's got different things that it can do to the normal physiology. So one person having a BRCA gene, a family with a BRCA, doesn't necessarily mean that it portends their risk. Yes, it does, more than the general population, but it doesn't put it at that 80% chance that you will develop this cancer. But the more your family, so if 2, 3 have this BRCA, then please, that's when you need to go have genetic counseling and testing, because doing genetic testing on the general population, you will pick up a lot of abnormalities, and those sometimes need to be explained what the implications are. So it's not just something to be taken lightly to say, let's go do genetic testing on everyone.
Okay, thank you very much. Let me go back to Ruth. This Pakamisa project, can you just give us a sense of the rollout, the revamped, project? Just a sense of we getting into 2021. What is likely to be happening, in the rollout of the project? Remember, Salome said we need this to be in all provinces in an equitable way. So I just want to hear from you how you guys, as the head of the project, how are you planning to roll it out across the country?
So we want to scale it up. We started at the moment with Gauteng, with mainly Tshwane, And we're going to be doing a lot of campaigns in the communities, but we also making sure that that digital program is actually in place, because we want to make sure when we start with the campaigns, whatever is happening in the communities has to feed up in real time into what is actually going to happen in the in the clinics as well. So you should be, as a healthcare practitioner, be able to see in real time what has happened at any point in the patient journey. And what it also we want to do is that it has to link to the protocols. It has to link to the guidelines that are in the healthcare facilities. And the reason why we want to do that is to monitor the management of care. If the guidelines or protocols are being followed to the T, but the outcomes are not there, then the question is, what is actually happening? Are those protocols and guidelines up to date? Should they be reviewed? Should something be done to actually update those guidelines and protocols? That's the first thing. Then the other thing that was happening in the past is that the community caregivers or whoever is working in the communities, they will do the screening, they will do the education, etc., but it was not measurable. And if you cannot measure it, you can't really do anything in terms of outcomes that you get from there, because it's not visible, it's not objective, you can't really use it. So that's why we want to map it as well. And then the other thing is that because we want the patients to be, or the community members to be empowered, we want them to know what to look out for. Because if they know what to look out for, they are going to get to the point of entry, which is the clinics or wherever they're supposed to be, quite quickly and quite early. And also, if they know what is happening, they are well educated. Let's say they get into their first point of entry, in this case, which is usually the clinic, and they don't get the service that they require. They will know exactly also what to do and where else to go to. Because sometimes what happens is that they get into the facility, but they're not attended to, or they keep on being sent back to the community. And by the time this cancer is picked up, it's actually on stage 3 or stage 4, which is quite late. So like I said in the beginning, most of these cancers are treatable, they are curable. But at the moment, people are dying and they don't need to die. So that is what we want to stop. The other thing that we are looking at is the concept of task shifting. So at the moment, we want to make sure that the healthcare practitioners stick to what they should be doing in the facilities. And then the screening, the awareness, and all the other things happen in the communities. That way, you actually make sure that there are efficiencies. But if you don't basically connect what is happening at all those touch points, it's not going to help as well, because everything is just going to be fragmented. Yeah. And so you will see next year that there's a lot of work that is going to be done with the community caregivers that are in the communities. There's going to be a lot of campaigns that are going to be happening. There's also a lot of awareness in terms of social media platforms, in terms of community radio stations, because those are the ones that most of the community members listen to. And then we're also going to make sure that we partner with private care in most circumstances, because we want to make sure that the cancer care is equitable. You mustn't be getting better care because you're in the private sector versus the public sector. So we want to make sure that any patient that has got cancer should be able to get the innovative solutions that we are providing in both private and public sector. The other thing that we've done, if we look at the education side, what was happening is that in the healthcare facilities, there is no adequate training of cancer, especially in the primary healthcare centers, which is where the patients go to first. Those are the first points of entry. So what we are doing now, we have partnered with certain organizations. One of the organizations that we partnered with is the Breast Health Foundation that is based in Cape Town. So they are going to provide training to the advanced nurses, the ones that are at the breast clinics. And the reason why you want to do that is that we want to make sure that the education is standardized. But also we are basically partnering with Stellenbosch. Stellenbosch is going to give an accredited course. That is a 6-month course. It doesn't exist at the moment. So whatever training you have is not really accredited in terms of the advanced nursing or in terms of cancer care. And then if you look at the primary healthcare nurses, we are going to be using the online training and the face-to-face training, but it's going to be provided by the Breast Foundation. So the Breast Foundation is going to provide that training because we want want to make sure that anybody who comes into that point of entry knows who they're going to meet in the first place, but also when they meet that person who is a nurse at the primary healthcare level, basically whatever is supposed to be done in terms of proactively looking out for the cancers is done. At the moment, most of it is actually reactive from what we find out. Then you're also going to see there's a lot of partnerships that we're also going to have across the departments as well. At the moment, you find that in South Africa, we don't have a lot of oncologists. We don't have a lot of breast surgeons. We don't have a lot of urologists. But what do we have the most of? What we have the most of are nurses. We've got the medical officers. We've got the general physicians, etc., the family physicians, etc. So how do we make them play an important role of actually being the ones that are proactively looking for those cancers, because they are in the majority, but they're also the ones that are most likely to basically have the first point of entry in terms of the patients going to them first. And then by the time they go to the oncologist, the time they go to the urologist and all these other specializations that are related to cancer, it's quite late. They're already on the advanced stages. And at the moment, we are not seeing that. We're seeing that there's a lot of pit stops in between, but what is supposed to be done in terms of cancer, in terms of the diagnosis, in terms of the treatment, is actually not happening early because those people are also not aware.
Yeah. Thank you, Ruth. I'm going back to Salome. I'm going back to you. Salome, right. We've listened to Dr. Molefe. We've listened to Ruth. You are on the ground. You know, you've seen ideas come and go, some working, some not working. You know, if I had to ask you, what are the 3 things that would make the most difference, you know, in terms of ensuring that people with cancer are actually, you know, taken care of, even better if they're identified at early stages?
I think what is for me,
I think the things that
the biggest challenge here, what we have, for me, always comes back to the individual, the patient, the community member. We need to make sure that we have people in our communities that are empowered, that are informed, that knows exactly what to do when.
Yes.
And that for me is very important, that we actually make sure that we start achieving that. And that will have to be with various strategies. If we go into breast cancer has been around, it has been made popular for many years. Yes. We've got October month. Everybody knows October month is breast month. Everybody talks about it.
Yeah.
But yet nobody starts talking about when is it really Men's Awareness Month, and what is it that we do about that? So those for me is, for instance, the very, very first challenge. How are we going to change that environment so that we can make sure that we deal with all communities? I also feel very strong about the fact that, particularly because we are dealing with men with prostate cancer, we will have to start thinking out of the box in terms of how we're going to deal with it. We know it in this country. We have many cultures. We have many languages, and we also have many religions. Those are the 3 aspects that we will have to take into account when we start the conversation happening in every community. And I emphatically will say to you, the conversation that happens in America or in Europe is not the conversation that's going to happen in South Africa. So we will have to devise our own messages for our communities, in Limpopo, in rural KwaZulu, in rural wherever. We have to devise our own. And there's very interesting ways that we can do that with storytelling, and bringing that on board. So that for me, for instance, I would think is the very first one. The next one is to, for me also, is to bring on board, and Ruth mentioned that very particularly, the community health workers. There's a link between the community and the clinic, and that becomes the community health workers. We've got a subset of community health workers in this country that is doing enormous work. We've seen it with COVID. We've seen it with HIV and TB. We are now going to task them with an additional burden, and that is cancer. So training them, educating them also in the cancer language, I want to say, is going to be another challenge, so that we can make sure that I want to say that navigation from me, the patient, picking up a symptom to what is it that I do next? Can I go to the clinic? Where do I go to? Navigate me through the system, because that in fact I think is another challenge that we have with our rural provinces, where we have our treatment centers for cancers, mainly in the bigger cities. Yes. We're talking Johannesburg, we're talking KwaZulu-Natal, we're talking Cape Town, that kind of Steve Biko. But when you start talking about the local hospitals, patients don't know where to go to. And it's that navigation of making sure that we are able to navigate a patient through the system that I think is also going to be the other challenge that we will have to overcome. And I think the third one for me in particularly is going to be the link. Yes, if we can succeed in literally diagnosing our patients at an earlier stage, it will release some of the burden on our treatment centers. But there's another challenge that faces us, and that is the challenge of emotional support, because many of our patients do not have that emotional support. You're diagnosed with cancer, which is a potential, it is a dread disease, but some people mainly see it as a death sentence. It's not necessarily a death sentence, but how do I deal with it? How do I cope with it? I'm losing my job. I haven't got an income. I need to travel for treatment, and now I have lost my job, or I don't know how to get to the treatment center. All of these things have to be navigated, and that's emotional support, that we need to make sure that there's emotional support. And that is the role that also a lot of the non-profit organizations also play in terms of the emotional support. Once the patient has completed his or her treatment at the treatment centers, and we've got extremely good treatment centers, that patient goes home. Who picks up the pieces? Who makes sure that the patient will actually go for follow-up visits? Who makes sure that when the patient is in the palliative stage of life or end of life, that there is care? And so apart from what we're setting out with Pakamisa to do, there are other challenges that we also need to make sure that we bring that on board through the collaborative approach. And I am quite sure that with Pakamisa, we will be able to do that completely.
Yeah. Thank you, Salome. There is a question for Ruth that has come up from some of the viewers. There's a question from Francis Urebwa, who's asking, how are you going to measure the impact of these campaigns? So just think about that question. I just want to go to Dr. Molefe in the meantime. Dr. Molefe, right. You guys at Steve Biko Academic Hospital, you service a huge area. You even draw people from Mpumalanga, as far as Mpumalanga, because the services in that province, as far as cancer is concerned, are still quite rudimentary, I'm assuming. Hence the need for patients to be referred to you. How are you guys coping? Because you've got people in Gauteng, you've got this other province that you are also supporting.
We show up. We go to work in the morning and we hope for the best, and we try to provide the best service that we can. Because we understand the limitations of our system.
Yeah.
It's not something that the patients can do anything about. It needs a collective approach to try and fix these things, because indeed there aren't any other hospitals, and because there's a shortage of oncologists. I don't know whether oncology is not fashionable or what, but those are some of the things. There aren't enough of us. So that's why we need to then land on the systems that are already there. We need to make cancer, less of so scary to junior doctors and doctors who are not trained in oncology. It needs to become a sort of HIV, TB, hypertension type of thing, diabetes. Diabetes is managed from your local clinic right up to Steve Biko. It doesn't need a cardiologist or an endocrinologist to go treat diabetes in a local hospital. So those are the things that need to happen to cancer as well. We need to, as also academic centers, to empower the lower level hospitals to be comfortable in treating this disease.
Yeah. And if I just remember now, just going back to the launch date, Dr. Kanyile, that you work with, mentioned that at times you guys have got a challenge as a tertiary hospital where you've administered treatments, but then people have to go back to their communities and you keep people that should have ideally been referred back to lower levels of care. Can you just maybe expand on that, because it is something that I found interesting during the launch day?
It's some of those things, because we've made training, oncological training, so specialized and so subspecialized that it really doesn't filter down to our less junior doctors or untrained or unspecialized clinicians. And so when we do end up treating, let's say, a patient with breast cancer who's metastatic, and we're giving them chemotherapy, we give the chemotherapy and they go home to a lower hospital. Should something go wrong, there's a sense that we're getting that there's panic. People are not comfortable managing this, so the patients invariably have to then come back to us. Or in a less advanced setting where a patient with breast cancer has gone through a mastectomy, has gone through an adjuvant therapy, and now is on in remission, in a complete remission, and is on a tamoxifen, which is a tablet that just reduces your risk of the cancer recurring. But still, we still have to follow up these patients. There is no way where they can go and be monitored whether the symptoms are suggestive of a recurrence, where they can at least instead of having the burden of finding money to travel from your home to your nearest town, then from there all the way to Pretoria just to get a tablet which could be given at your local hospital or clinic. So those are some of the issues that we need to, as we progress and as we go along, to empower our lower level hospitals to feel comfortable with cancer. It's not such a scary thing. We need to be more comfortable with it. When we talk about cancer, we need to be talking with cancer on the same breath as diabetes, as hypertension. We need to have a culture of dialogue and discussion around this.
Thank you, Doc. Ruth, can you help to answer the question that was posed by one of the viewers? How are you going to measure the success of the Pakamisa project going forward? What are your KPAs or KPIs and stuff that really makes a difference on the ground?
Okay, so there are different metrics depending on the different KPIs. But one of the most visible things probably is in terms of the communities, because when you do the screenings, it has been very important for us to collaborate with the district to make sure that there is a very good and strong relationship between AstraZeneca, the partners, and the district clinics. And the reason why we did that is because we want to ensure that whenever we do the campaigns in the communities, the clinics are also involved. And why is that important? It's important because we will have sisters that are actually responsible for triaging those patients. So when we pick up issues, let's say you've got 100 people that you've screened, and then you pick up issues in 15, those 15 will know exactly where to go, which institution they go to based on where they live, and they'll also have a name of a sister that they need to go to that will triage them within the system. So it will be measured. And you remember the digital platform that I spoke to that is actually in real time. So across that entire patient journey, one will be able to really see, I mean, out of the patients that were referred, how many went through the system? And when did they go into the system? So you'll also be able to measure the timelines, because sometimes what happens is that you refer the patients, but they take longer to get in there, and they have to be then followed up by the caregivers. So you'll be able to see whether there was delays or whether they actually went there in real time. And then when they get into the system, you should also be able to see the timelines, the waiting times in between wherever they're supposed to be. And if there are pit stops, which they shouldn't be, because if you look at the policy, it says that it actually should be an open policy, open access policy, where if you really realize that you've got a breast cancer and then you have to go somewhere, you should be able to actually get in there, whether it's a breast unit, whether it's any other area. You shouldn't be turned back to go to your clinic or whatever. So you should be able to see those things there as well. So that will be completely measurable. And then if you look at other things, like for instance, like your communications, your PR, etc., we'll obviously use this, the same measurements that your PR companies use, the media companies use, etc. And then the other thing that we'll see is, because we're looking at the patient outcomes. If the patients, the communities are being trained and there's a lot of awareness, are they now coming early into the clinics? At what stage are you picking them up? If you are picking them up at stage 3 and stage 4, what percentage now are you actually now picking up at stage 1 and stage 2? Because that's what we want. Most of the times, what we're finding out is that the patients in the private sector, they do well, but it's not necessarily maybe because the treatment is so much better, but it's because they are getting into the system much earlier. So those are the things that we'll be able to measure. And like I said before, because that whole digital system looks at the entire management of care of the patient based on the guidelines and the protocols, we'll also be able to see who are the nurses or the sisters that are actually adhering to those protocols and those guidelines, because that digital system is not going to allow you to go to the next step when you haven't done what you're supposed to be doing at the primary healthcare center. And also it will help with the other non-communicable diseases, because for instance, you're getting in there because you've got a cancer issue, but they're going to test you for diabetes. They're going to test you for high blood pressure. They're going to test for other things that are basically supposed to be tested according to protocol. And if that is not done, you can't go forward. So that will also help as well.
Okay, thank you. Salome, this question that I posed to Ruth, the person who posed it has made a follow-up and said, actually, she wants you to answer. But there's been another follow-up question. She's saying, this is Francis Kurebwa, saying, Salome mentioned policies around prostate cancer that are still being at government stage. Any timelines around that? Not that I have lost faith in the government. So that's the question for yourself, Salome.
So we envisaging that the prostate cancer policy will be finalized in 2021. I mean, it is, let me say that to you, I think we've waited enough. We've waited long enough. We also are quite responsible, and I want to say, in our advocacy and pushing government, but you know, and at the moment, yes, we know there's a lot of attention on COVID, but I think come 2021, we need to start pushing government more and more to actually then finalize the prostate cancer policy to enable us to actually start implementing Pakamisa prostate as well, because otherwise I want to say you can't do it. Because you're going to actually, what are you going to do? There's no guidelines, there's no, the provinces are not going to be ready, etc., etc. And that is in fact what is so important, that why policy is important, because policy makes sure that you actually implement your services from the first moment and go right through all the steps, take the patient from the community through all the pathways of care and again back to the community. Without that, we will not have equitable services. So that for me is very important. And I'm quite excited about all the training that's going to be rolled out specifically for breast. I would like to, and I just make the correction there, it is the breast course for nurses. I think Ruth was just at that moment, she was in her mind thinking of the Breast Health Foundation. So it's the breast course for nurses that's doing the training course for the nurses on clinical breast examination, etc. And hopefully we can then start doing exactly the same for the prostate. However, two of the points that both Ruth and Dr. Molefe has made is this whole thing of, I want to say, monitoring the patient, making sure that we follow that patient from the first step right through. That, in fact, is another challenge that we have in making sure that our cancer services for the future will be good enough, because at the moment we do not have that monitoring system. If we are able to implement an electronic patient monitoring system that picks the patient up from primary health care and right through the whole system, so from diagnosis right through, then we will be able to see whether we are successful or not. At the moment also, cancer in South Africa, yes, it is a registrable disease, but not all our patients are registered. So our figures for cancer is not necessarily reflecting the true burden of disease. And you can only measure the success of the management of your program if you also know what is the death statistics, because it's the survival, actually, that survival statistics is very important. And I can say to you that one of the members of the Cancer Alliance, and very particularly in the new year, is going to launch that campaign as well, where we actually saying we want to be counted. So that's the message that we're starting to throw out. You stand up and speak up, because you in the community, you are important. And if you don't stand up and speak up about services that are not there or not good enough, then we won't know about it. But also what we want is, we want, in the same way that we did that for HIV/AIDS 20 years ago and said, go and be tested. We're now going to start asking cancer patients, count me in. Because so that we can start determining what is the real burden of cancer.
Thank you very much. As we wrap up, we only have just about close to 15 minutes to go. Now, I want to go back to Dr. Molefe, but there was a hand from Ruth. Ruth, do you want to say something? Because I saw a hand, or maybe you raised it by mistake.
Yeah, so I just wanted to add that in terms of the digital system that we're rolling out, it's actually privately funded. Government doesn't have anything like that at the moment. So we are funding for it as Astrazeneca, because we want to be able to show what good should look like. Yeah,
thank you very much. Dr. Molefe, now we are actually in the middle of a COVID-19 pandemic. There was a time where there was hard lockdown. level 5, level 4. And we've read, I'm not sure at an academic level, what studies have been done, but we've read that quite a number of other health challenges, they have been affected negatively in terms of compliance to treatment or rescheduling of interventions and things like those. What experience do you guys have? What has been the impact of the COVID-19 pandemic in the clinics that you run for your patients?
In our oncology clinic, during level 5, we saw quite a sharp decline in patient numbers, but a lot of them did still come in. Sorry, hello, Fundile. So what we've seen, we saw a sharp decline in our patients who were already in our system and diagnosed. However, another thing that we noticed is that the number of diagnoses were going down. So patients, because other clinics had shut down and restrictions to movement, patients were not coming into hospital. And so what we're seeing now, the fallout from that, is that a lot of patients who were perhaps diagnosed and treated at a surgical point, at an earlier point, and required our adjuvant therapy, are only coming in now as the restrictions have lessened. And we're noticing that then a lot of patients who had symptoms around the time where the lockdown was being initiated delayed their presentations to hospital and are only now presenting. So we're seeing that effect, that it did have a knock-on effect, this lockdown, in our patients, and the fear as well of getting infected. And another thing for us, because we also now had to tailor our therapies to this, because we know we give chemotherapy, and chemotherapy is immunosuppressive. So now suppressing someone's immunity, and then they have to get into a crowded taxi, or those are some of the things that we had to do. So we had to also try and tailor our therapy to less toxic to the immune system. So it did have an effect. I think we'll only have a full picture later on.
All right. I think we just need to now wrap up. I want closing remarks from Salome, and then Ruth, and then you will be the last one, Dr. Molefe. Just your closing remarks about this project, and how you guys see yourselves adding value to make sure that its vision and mission is actually achieved.
For us, Pakamisa is really the implementation of what we call the 4P principle: patient, public, private, partnership, where the patient is first and not last. So I'm asking every single listener today, make it also your vision to actually become part of your own health and your own future in terms of health-seeking behavior, and how you can influence other people to have positive health-seeking behavior. Become that first P, where you put the patient first.
Yes. Thank you very much, Salome. Ruth, your closing remarks.
We would really like Pakamisa to be addressing all the patient access issues, the awareness issues, education issues, and policy implementation. We want to make sure that it's inclusive, everybody is included, because we all want the same outcomes in terms of the stakeholders. And we want to make sure that at the heart of it, at the core, is the patient. The patient is empowered. The patient knows what to look for, and they actually the one that is driving their care.
Yeah. All right. I seem to have some challenges here. So, Dr. Molefe, your closing remarks before this thing gives me trouble again.
Yeah. So I think the best thing, you know, that will come from this is that, you know, our patients will receive the best care, the best cancer care, regardless of where they come from. This for us will help strengthen our links to the lower levels of care and ease the navigation of patients from the lower levels of care through to us, and hopefully improve their outcomes.
Thank you very much. I just want to thank all our viewers who have connected over the last almost 90 minutes as we were talking about the various aspects of the Pakamisa project, looking at that within the context of South Africa and also in the context of the world. So this is just the first of many that are going to happen. We'll pick up different relevant, topics that are still within the Pakamisa, mandate. We'll get people from the communities. We'll get people who are survivors of the various cancers. We'll get, community health workers. So look forward to more engagements within this area of Pakamisa. And I want to thank everyone who joined us. And also I want to thank especially my esteemed, guests on the channel. I want to thank you, and may you have a very safe and relaxed, festive season, as many people are starting to wind down because of Christmas, or just even if they are not people who observe Christmas, people who still want to spend time with their families. So I want to say thank you to everybody. May you still enjoy the rest of the weekend. Looking forward to seeing you again. Thank you very much. Thank you.
Thank you. Take care, everybody.
Thank you, Dr. Molefe, and thank you, Ruth. We will make sure that the little glitches are sorted out. And
Thank you.
Thank you very much.
Okay, thanks.